All right. Hi, everyone. First, I just have to apologize for my voice. I've been battling a cold, one cold after another, and I feel like I sound like I've been smoking for 40 years, but I can assure you it's just a cold. So my name is Kim Woods. I'm a member of the Adult Cystic Fibrosis Advisory Committee, or the ACFAC, and on behalf of our entire committee, I would like to welcome you all to the third webinar in our educational series on fertility and family planning for people with cystic fibrosis. Cystic Fibrosis Canada's Adult CF Advisory Committee provides perspective and advice on CF-related issues and advocates for public policies and programs to help people with cystic fibrosis. Members also foster and support an engaged and knowledgeable CF community. Among the committee's various initiatives, we are pleased to host this webinar series through which different aspects of fertility and family planning will be discussed by a variety of expert guest speakers, as well as people living with CF that are willing to share their personal stories. Please note this is an educational webinar series. CF Canada cannot provide any medical advice, although the series will feature a few CF clinicians and other healthcare professionals. We highly recommend that all persons with CF seek guidance from their CF clinic care team regarding their own family planning process. And today, I'm excited to hear from both speakers. We'll hear from Dr. Sigrid Ladores, a health professional from Alabama, Birmingham, who is very knowledgeable in this field, and Hattie Dunstan, an adult with CF that will be sharing her patient experience with family planning after transplantation. We will then take questions after hearing from all of our speakers. So today we are honored to be joined by Dr. Ladores to speak on our fifth topic of the series, fertility and family planning after lung transplant. Dr. Sigrid Ladores graduated from the University of Pennsylvania with her BSN and MSN degrees. She's a pediatric nurse practitioner, clinical nurse specialist, and certified nurse educator. She earned her PhD in nursing from the University of Central Florida and is currently an associate professor at the University of Alabama at Birmingham. Her research areas include chronic illness, specifically cystic fibrosis, and concerns related to reproductive health, fertility, and quality of life. Her research is funded by federal, foundation, and intramural grants. She teaches nursing students from pre-licensure to doctoral. When Dr. Ladores is not teaching, writing, or conducting research, she is in leadership positions in various professional organizations. So Dr. Ladores, it's over to you.
Thank you so much. I hope everybody can hear me okay. I first want to thank Cystic Fibrosis Canada for inviting fertility and family planning after lung transplant. It's a topic that's near and dear to my heart. So thank you, CF Canada and the organizers. I too am recovering from a cold, so I apologize if I cough in the middle of the presentation. Hopefully not. I've got lots of fluids next to me. But again, thank you for having me. So without further ado, let's get started. Presentation disclosures, I don't have any actual potential conflict of interest. By UAB, the CF Foundation, and the NICHD. And just as Kim mentioned, this presentation is provided for informational purposes only, certainly not a substitute for professional medical advice. And truthfully, not much is known about these topics because they're emerging, they're new, and it's a wonderful time, I guess, to venture into health in general, because it used to be, CF used to be a childhood disease, and now we have individuals with CF who are living full and healthy lives into adulthood and beyond. So while not much is known about these topics, we definitely would like you to consult your healthcare teams and continue to participate in research so that you can contribute to building that knowledge base related to these topics. So I have three main objectives today, and the first is to describe fertility and family planning options transplant, then I'd like to highlight some of the non-biological avenues to become a parent, and then finally discuss considerations after becoming a parent. So what are the basic concepts related to fertility in men and women with CF? This might be a review for many of the audience here, but I'd like to highlight that approximately 98% of men with CF have what's called CBAVD, or congenital bilateral absence of the vas deferens, and that results in infertility. This means that they are infertile, but they are not sterile. So I'll describe the difference between the two in the next slide. For the women with CF, generally they have normal reproductive structures, and except for those who have really low BMIs and severely malnourished and have low pulmonary function, they do have normal or near normal menstrual cycles. Some of their issues related to having decreased fertility primarily results from having the thick cervical mucus that blocks sperm transport. So let's talk about men first and followed by the women. So for the men, they do have, for the most part, within the testes that can be obtained using needle aspiration and then cryopreserved or frozen for later use. It was in 19 aspiration for a man with CF was done, and that resulted in a biological child. We have come a great ways from 1988, and techniques related to assisted reproductive technologies just getting better and better every day. And I want you to remember this picture because I'll highlight this picture again towards the end of my presentation, this cutie pie right here. So I mentioned fertility preservation. Fertility in men can be accomplished using assisted reproductive or in vitro fertilization, or IUI, which is intrauterine insemination, also known as artificial insemination in some layman's terms. And these techniques can facilitate conception using cryopreserved sperm or frozen sperm. Unfortunately, conception rates of men with CF using their own aspirated sperm is truly unknown because it is not routinely collected by the CF Foundation Patient Registry. And I put question mark CF Canada because perhaps it is already being collected as part of your patient registry. It is not through the CF Foundation here in the United States. So pre-transplant, we understand that sperm can be aspirated from the testes and then stored for future use. This really is the best case scenario, especially if men notice that their lung function is declining and that they want to make sure that they plan ahead. So this is the ideal case scenario. Then frozen sperm can be saved for many years, in fact, to be used once the man is ready to create his biological family. Post-transplant, I'll talk a little bit. Meds required post-transplant do carry some risks and can result in defects. Again, not much is known about this topic because we don't routinely collect this data, but there is preliminary and emerging data out there that these anti-rejection meds can be teratogenic or can create some birth defects. Because of this risk, many IVF or in vitro fertilization clinics and fertility specialists don't advise using fresh post-transplant sperm. And if needed, the idea of having a donor sperm can be brought up with these men. Why am I passionate about this topic? I'll share with you a brief story about this case report that I actually wrote up and got published in the journal Experience last year. And it's titled, "If We Would Have Known, A Couple's Regret Over a Missed Opportunity to Have a Biological Child After Lung Transplant." So this case study involved a man with CF, a husband with CF who undergoes a lung transplant. They were married for a few years before transplant, decided that his health was declining and that they would pause their plans to create a biological family until after transplant. Unfortunately, he was never told that sperm could be aspirated before transplant in order to preserve his chance at creating a biological child. When he and his wife saw a fertility specialist about 2 years after transplant. They were ready. They thought, hey, we'll get some good news. Let's get this started. And they received some devastating news. And I recalled interviewing this couple, and they were still heartbroken many years later. And they shared with me that that appointment with a fertility specialist and was given the news that they should not have a biological child post-transplant using a fresh sperm because it's too risky. He said that he felt like someone punched him in the gut and that he almost fell off his chair because he certainly did not anticipate receiving such bad news. Thankfully, there's a happy ending in this story, in that this couple now have adopted 2 daughters who are biological daughters, in fact, and they're thrilled as can be. But in that moment, they thought, why couldn't anyone have told us that I should have done some fertility preservation and frozen my sperm so that it's ready post-transplant? He said that he could have benefited from these fertility preservation counseling before transplant, so that at least it gave them the option of pursuing, this route after transplant. So for female fertility, pre and post transplant, we know that there's some work on collecting data on this. This is from a team in 2014 that published results on collecting data from 1991 to 2010, so about 20 years worth of data, where they looked at pregnancy post-transplant. And ideally, you want to delay getting pregnant 2 years post-transplant. And I'll explain that in a little bit more detail in a minute. But these authors released a report that said in almost 20 years, they found 24 females with lung transplants who reported 33 pregnancies. And out of those 33 pregnancies, 19 resulted in live births, 11 miscarriages, abortions. So the numbers aren't a lot. It's not great, but this is the most recent statistics that that we can find in the literature. For egg retrieval, as you go through fertility treatments, egg retrieval should be done ideally before transplant. Again, kind of planning ahead so that you have your eggs retrieved and then frozen, ideally for use post-transplant, and preferably in a surrogate. Again, these are ideal case scenarios. If you have the ability to use a surrogate, a gestational carrier or a surrogate, that would be the ideal case scenario, because then the woman's health is much more protected and preserved. And surrogacy can certainly be accomplished before or after transplant. So some best practices that's out there. We know that there's not a whole lot of data out there, and so we've identified a study released in 2015 that describes some of the best practices related to pregnancy post-transplant specific to CF. So this is a good article to consult, and I've just summarized a few of the key terms and pearls from that article. So first thing is, you need to make sure that the man or the woman consult with their transplant team first before kind of other consultations. Other consultations that would be recommended include having a fertility specialist present, a maternal fetal medicine specialist, a high risk OBGYN would be great. And again, at least about 2 years post-transplant, at least 2 years post-transplant. And the idea is you want your graft possible, and then your anti-rejection meds also as stable as possible. And if you can decrease the meds and the dosages for as low as possible, then that would be ideal. You'd want to have good overall health, both lung health and proper nutrition, and good family support as you go through something like this. You'd want to have no recent episodes of acute rejection or evidence of ongoing chronic rejection. No acute or chronic infections, and I've listed a few here, like HIV, hepatitis B or C, CMV, which is cytomegalovirus, HSV, which is herpes simplex virus, HPV, human papillomavirus, syphilis, rubella, varicella, and toxoplasmosis. So these are just some of the infections specialists want to screen out. You'd want to have updated vaccinations and hopefully good stable vital signs, specifically looking at blood pressure and good kidney function, renal function, and I've listed some levels here that are shared in the article. Proteinuria is, again, a function of kidney, renal function, and other health indices. So you want to make sure that they check all these things before going through a pregnancy post-transplant. If the woman does have diabetes, whether it's CF-related diabetes or your traditional type 1 or type 2 diabetes, you'd want that to be adequately controlled. And now for the immunosuppressive regimen, this is listed in the article that if the woman has on her regimen prednisone, azathioprine, cyclosporin, and tacro, you'd want these as low as possible. So having the lowest possible therapeutic levels if you're not able to completely discontinue these meds. They may be safe during pregnancy, and I've highlighted may. However, I've also bolded mycophenolate, sirolimus, and everolimus as being contraindicated, and the recommendation is they be stopped at least 6 weeks before conception. And this can be really tricky and can be risky and dangerous to have to stop your immunosuppression medications 6 weeks before conception. So a lot of things to be considered and a lot of things that need to be discussed with your healthcare teams. So what are some risks post-transplant? So for pregnancy risks, the study did show that there is an increased risk for premature birth and low birth weight. And I'm very thrilled to be sharing today's talk with someone who's gone through this experience, and she'll be able to share with you exactly, what she did, how she made the decisions, and what she carefully thought about. And she'll be able to speak directly from her experience. So premature birth, low birth weight, those are the biggest risks to the baby. There's also a risk for miscarriage, and the frequency of miscarriage is about 40 to 50% post-lung transplant, but the risk of birth defects is really no different than the general population. As for lung rejection, this is the biggest risk to the mom. The literature says that there's no increased risk, only for those with stable graft, but there is risk for acute rejection in about 36% in pregnant women, especially when their graft is not stable. So preeclampsia can be also increased, that risk. High blood pressure can be increased, and diabetes, whether that's gestational diabetes, CF-related diabetes, or regular diabetes. Infection can also be increased during pregnancy post-transplant. After doing egg retrievals, the risks include, but we just don't know. Again, really because of the immunosuppressive medications that patients are on. Most IVF clinics do not recommend doing egg retrieval post-transplant. And again, it is ideally best to have these procedures done before transplant and having that plan in place so that they can finish the rest of the process post-transplant. As for breastfeeding, there's not a whole lot of data on this, but I did pull up something from the 2013 article. And so we noted that for medications of known toxicity without a safety threshold, like mycophenolate, these medications, breastfeeding is really not advised. It's too risky. For those meds that seem to appear to be safe at low or unmeasurable levels, such as your tacro or cyclosporin, thought to be safe, like your corticosteroids like prednisone or azathioprine, the infant's serum blood levels for the baby should be monitored for any kind of drug levels, especially after the first few weeks of breastfeeding. For meds that have no known safety thresholds, breastfeeding should not be advised. Again, we have limited data on this, and it is best to consult your healthcare team. Each CF center may have different advisor recommendations, and it's really best for the mother or the couple to have these conversations, regularly and as needed. Okay, so moving on to our next main objective, which is to highlight some of the other non-biological avenues to become a parent. Adoption is certainly one path to achieve parenthood. And in my research, because I'm from the United States, I had to dig a little deeper into what Canadian laws look like. But Canada, generally adoptions in Canada are either public, private, or overseas, or also known as international adoptions. Having CF should not disqualify the person from being able to adopt. And again, there's caveats to that, depending on the agencies that you work with. Private and international adoptions are usually faster, but they can be very expensive. And they range from anywhere between 10 to 50,000, sometimes a little less, sometimes a little bit more, depending on the agency that the couple works with. International adoptions are the most common, and we've identified that about 2,000 adoptions per year occur in Canada. This is not specific to any kind of lung transplant or CF related. This is just general numbers in Canada. Fostering is another way to, achieve your desire to take care of children. And unfortunately, this is just a short-term temporary arrangement, and children are placed with you until the parents decide what they want to do. Oh, that slide got cut off. Until they change their situation or make a decision about the child's future. That's what the rest of the bullet point should have said. So fostering can lead to adoption, or it may not, depending on what the biological parents end up doing, whether they relinquish the parental rights or they want the children back and work hard to get that right back. Gestational surrogacy is something that I think my co-speaker will be able to talk about, but it is important to check laws for legality. In the US, different states have different laws, and you'll need to be able to, identify which states have gestational surrogacy as being legal, as a legal option, and then work with hopefully an attorney to make sure that everything is done properly. And certainly it is an option to not have a child or children, because post-transplant pregnancies can be risky and come with significant risks to both the mother who carries the pregnancy and the fetus that's developing. Some may look into the option that the risks far outweigh the benefits. Adoptions and gestational surrogacy can be expensive, we mentioned that, and usually require a long wait with no guarantee of a match. Again, you just need to be able to have these discussions with not just your partner, but your healthcare team, and certainly your other family support systems, and need to be able to weigh desires and realities to achieve what you want in life. Whether that's to pursue a career, be successful in it, to protect your marriage, because going through any kind of fertility work can be really stressful on the marriage. If you'd like to continue traveling or having children, it's really a conversation that needs to be had probably very early in a relationship. Being honest and start planning, but having children or not having children could mean for your family. All right, so finally, third objective is to discuss considerations after becoming a parent. It's a balancing act. I certainly in that boat right now where I'm a working mother, and when my 4-year-old had a cold this past weekend, he only wanted mommy. And he be there, and the lack of sleep and the exposure to all kinds of germs and microorganisms. That's the reality of being a parent, and that you have to balance whether that is something that you want to dive into. So the balance is for individuals with CF. They need to be able to take care of themselves as best as they can, despite the parenting duties. So they still need to go to their CF appointments. They still to maintain their health regimen daily. You can't have a day off. Same with parenting, you can't have a day off. And essentially, how do you manage exacerbations when they happen, when you're in the hospital? So a lot of things need to be considered, and you have to be able to have these honest conversations with your partner and your family care team. I think I don't really need to put this slide in, but I thought it's a good reminder that kids can harbor a lot of illnesses, and they're happy to share them with their parents. I am a prime example of that right now. So toddlers, young children, they get many, many illnesses a year. I'm looking at the numbers right now, and my son probably is 4 years old. He has been sick 3 times since the beginning of 2020. So I have a lot more illnesses to go for the rest of the year. It's just a lot of germs that's being introduced into your home, especially if they attend daycare or school. They bring them back to the house. That's just reality. And so parents with CF should consider the amount of illnesses, and consider if they're able to, having a nanny or decrease the risk of illnesses being brought into the home, especially during the early years. And obviously, financial feasibility of this should be considered. These options can be really pricey. So fertility discussions do matter. It's all about planning ahead, having these conversations with your partner. Certainly with your partner, disclosure is a big thing. The what, when, who, how, and why. Meaning, do you introduce the topic with someone that you just started dating, or do you wait until things get really serious? But the conversation needs to happen, and full disclosure truly is encouraged. And how you do that, and why you would want to do that, and when. Those are all things that need to be kind of reflected upon and thoughtfully delivered. If the person is involved in a serious relationship, it would be important to obtain the partner's family history. And specifically, if the risk of CF is there within the partner. And then we encourage partner genetic testing to be done, and discuss the need for it, and discuss the next steps. If the results come back positive, then you have to have the follow-up, a talk about what do you do? Do you proceed with certain steps? And thankfully, there are certain procedures that can be done, such as pre-genetic diagnosis, that pre-implantation genetic diagnosis that can be done with an embryo, to ensure that the embryo that resulted from IVF can be placed back safely, and that that embryo is determined to not be a CF embryo, meaning that this embryo has been cleared of having the CF disease. So again, the conversation about when the best time would be to become pregnant, or to get the partner pregnant for men with CF. Lots of conversations need to happen. So some questions to consider related to this topic. Just a few, that it's not an exhaustive list, but we need to be able to think about, is raising a child consistent with your lifestyle? How would your daily life change? Are you willing to make these compromises? Would your partner be capable of raising a child alone if he or she were to lose you? These are tough conversations about mortality, early death, and unfortunately, these conversations need to happen, especially about bringing in a child into the world. Have you and your partner discussed how you'll split childcare responsibilities? Is he or she willing to take on a bigger parenting role, especially when the person with CF is not feeling well or is hospitalized? If you plan to have a child through an alternative family planning method, can you afford it? It's expensive to go through adoption, surrogacy, going through fertility treatments. And hardly ever will you find an insurance company that will cover these things. Do you have a strong support system like family, friends, or community that can step in and help? Has your partner, spouse, or donor been tested for CF? So again, the more information you have going into the process, the better hopefully the outcome and experience will be. So why is this work important to me? So you've seen this picture in a previous slide, and I'll tell you who this is. This is my son, and this is my husband. So this little baby boy who's chunky and apparently naked in this picture is named Cooper, and my husband, Andrew. And Andrew is a 47-year-old man with CF. And so I'm very fortunate in that my work, my professional, and my personal lives intersect in CF. I love being able to hopefully impact and improve the lives of my friends with CF, my family. And so Andrew was born with CF. He had the classic textbook case of CF. He was born with a meconium ileus and had surgery at day 2 of life on his gut. And we've been married almost 21 years. And it's a far cry from when he was born and his pediatrician told his mother, my mother-in-law, that he probably will not live to see his first birthday. So here he is, still kicking butt, and he is 47 years old as of this past January. So these are 2 boys. His 12 years old Asher, and then 4-year-old named Cooper. Both boys are born from our fertility journey. As typical of men with CF, my husband has CBAVD, he has male infertility, but we were determined to at least try to create a biological family if we can afford it. And we have the reserve, meaning the physical, emotional, and mental reserve and financial reserve to go through the process. But adoption was always there also as an option. So we decided let's try and see if assisted reproductive technology can make it happen for us. But first, we went through my own genetic testing. I joke that my husband married me for my clinical nursing skills and my genetics, because I am Filipino, and being Asian means that there's probably a very low likelihood that I carry the CF gene. And in fact, that's what my testing showed. So our boys are carriers, but they don't have CF. So once I got cleared with my genetic testing, we went ahead and aspirated his sperm and showed that his sperm is there, but it has low motility. And thankfully, we were able to use ICSI, which is intracytoplasmic sperm injection, where they were able to introduce his sperm directly into the egg to promote and facilitate fertilization, and that's what we were able to do. So after 5 IVF cycles, 5 years later, lots and lots of stress, we were able to become pregnant from a frozen embryo. So this frozen embryo is now a 12-year-old named Asher, and every April 23rd, we celebrate Popsicle Day, because that is the day when we took him out of the freezer. And on April 23rd, you will see us eat a popsicle in honor of Asher. After transplant and once Andrew's health has stabilized, we did 8 more fertility cycles using his frozen sperm. Thankfully, we had some left over before transplant. And so, did I mention? I don't think I did mention this before. Andrew is 8 years post-transplant. That would be important to share in this conversation. So after transplant, and when his meds are good, his health was good, we did 8 more cycles, and we were able, and on March 12th of every year, we celebrate Cooper's Squirt Day. So fertility conversations do matter, and especially in a time where our demographics are shifting. We have more adults living with CF than children, and we need to be able to have these conversations and these counseling from our CF care team and from other specialists, because we're looking at individuals with CF growing older, and they want to live full lives. So thankfully, I had resources, and I was able to get information, as we were going through our infertility journey. But hopefully, with some of the work that I'm a part of, we can continue sharing these types of information, so that families can be created, whether that's through biological with or without fertility treatments, or adoption, or using a surrogate. Then families can be made in many different ways. So Cooper was born 4 years after lung transplant. He's a little guy. And our Asher was born 4 years before transplant. Sorry, guys. Some take-home key messages. CF affects the reproductive health system for both men and women, but there is an opportunity and different routes to ensure creating a biological child using ART. Post-transplant pregnancies can be risky and need to be seriously discussed by everyone on your team. And discussions surrounding fertility and fertility preservation do matter, and they're important and critical for patients with CF and their partners. And some of the references and acknowledgements. And I was so hoping not to cough during my presentation. I was so close. And that's the end. Thank you so much.
Wow, thank you so much, Dr. Ladores. That was such a fantastic presentation. The content, everything that you covered was so detailed and really interesting information. And I really loved hearing your personal story too. That's really cool. I think it has such a big impact when, professionally you're in the CF world, but when you have your own personal story, I think you're just able to empathize that much more with people with CF. So thank you so much. That was really fantastic. At this time, we are going to hear from Hattie for her patient experience before taking questions. So Hattie Dunstan was diagnosed with cystic fibrosis at 6 months and hasn't ever known a life without the challenges that come with CF. At the age of 22, she went into end-stage lung failure and had a double lung transplant at Toronto General Hospital. Her 10-year lung anniversary is this July 2020. Happy early lung anniversary, Hattie. From a young age, Hattie always wanted to be a mom. She met her husband when she was 23, married him at 28, and together they started the 4-year process of having a biological child of their own through the wonderful gift of surrogacy. Hazel Grace was born last year in October of 2019, and Hattie shared that it's been the best 4 years of their lives. Hattie, it's over to you.
Hi, guys. Thanks for the introduction. I loved seeing the last presentation because it's so different, or a lot of my experience. I had to go through a lot of the same stuff. We had to have that tough conversations. I was pretty upfront with my husband right from the beginning, because the reality is I might not get to see Hazel get married. So we had to talk about, what it would be like if you were a single dad. Thankfully, we have such a strong support system. We actually live on the same property as Hazel's grandparents. So we kind of set ourselves up for quote unquote success, I guess. And we both work from home. So that also helps in raising her. So yeah, it was definitely a decision. It took 4 years to get her here, but it was definitely a decision before that 4 years that I really had to think about whether I grappled with a lot of guilt for a long time, whether I should bring a child into this world, knowing that, my life expectancy, I'm going to tear up, might be a little shorter. But I did so much research, and I actually talked to other lung transplants. There's so many Facebook groups. And one woman's story really sticks out to me. And she said that she and her husband, she got pregnant a year after her transplant, and her son is now 20 years old. And her husband actually died, the healthy one, when her son was 2 years old. So that just brought into perspective, you never know what happens. And someone else gave me some really great advice that, well, wouldn't you have liked to have been born? No matter what, like Hazel's here, she's alive. Because I did agonize over, well, what if she lost her mom young? But, I just think, well, she's here. She has such a loving dad. She has such a loving family. So that, we definitely discussed all that. And then we came to the decision. I have wanted to be a mom forever. I was that girl at 18. Oh my God, I want to be a mom by the time I'm 20. I was crazy. I wanted to go traveling after that, I realized. But yeah, so we discussed all that. It was really, really, really long process. Really emotional too, because I also kind of grappled. I don't even know what the word is. I'm so sleep deprived, guys. So if I screw up on my words, that's what's happening. But I struggled, I guess, with not being able to carry her myself. So that was the other decision we had to make. I would like cry in the grocery store if a pregnant person would walk by me, or, I'm 32 now. And a lot of my friends were getting pregnant, and that was really tough, watching them get pregnant and us struggling. It's still fresh. She's only 4 months old. And so, yeah, and then it was also hard for me to, we saw a counselor. That's part of the process of surrogacy. And I felt guilty that Tristan had to go through this alternative route to have a baby. And there's definitely a lot of guilt and struggles internally that you struggle with. But yeah, so I struggled with that. But so we decided to do surrogacy because I'm post-transplant. So we did everything post-transplant. I was only 22 when I got my transplant. So I wasn't even with Tristan. I didn't, it was, 10 years ago, people were not talking about fertility the way they are now, which I think is awesome. So I wish someone could have brought up the idea of freezing your eggs before transplant. So we had to do a lot of research. We joined Facebook groups, we joined forums. I talked to every single doctor under the sun. That's also why it took probably 4 years, because it took a year of doctor's appointments. I saw a high-risk OBGYN doctor. I saw a high-risk kidney transplant pregnancy doctor. I saw my transplant team, my CF team. And then we had heard horror stories about going to IVF clinics and them saying, what are you doing? You shouldn't have a kid, And thankfully, when we went to our fertility clinic, he was nothing but, I'm going to get you a baby. Like, we're going to do this, and you deserve this, and you're going to be a family. And so we had nothing but positive experience with our clinic, which was awesome. So after we did all of our research, we were concerned about, like the last presenter brought up, about the 6-week window going off of my rejection drugs. And I've been so stable for 10 years. We just didn't want to risk anything. So I didn't go off any of my drugs. We called the Mother Health Risk line at Sick Kids. We gave them a list of my drugs. They looked up studies and libraries and everything for us. And they thought it would be safe, since I wasn't carrying the baby on my drugs, that miscarriages and birth defects would be the same as in the general population, which I think is like 1% or 3% or whatever. It would be the same. So that's why we went ahead. We saw a really great fertility clinic. The egg extraction was actually a lot more emotional than I expected. I'm used to needles. I have diabetes, CFers, we grow up on it. We can probably tell them which vein to do as we're given blood. But it was emotional doing those needles, the hormones. I'd be watching TV shows, and Tristan would be like, "Oh, why are you crying?" And I'd be like, "Oh, she got into university. Like, it was just a hormonal mess. I can't imagine being pregnant and the hormones that come with that, because just the 2 weeks I was on fertility drugs was emotional enough. So we had to wait. I guess the whole process, I'll line it out for you, was in February, we called the fertility clinic. We got an appointment in June. So that took a long time to get an actual appointment with our doctor. Then we had to wait for OHIP to cover the egg extraction, which came in October. So then, we did the 2 weeks of the drugs, and it was nice that OHIP, I've heard how expensive it is in the States to have surrogacy. So thankfully, OHIP covers one egg extraction and one embryo implantation. So that saved us $15,000 and then $2,500 to get the embryo implanted. So we waited. So from February, we booked the appointment. June, we got the appointment. We waited till October till OHIP could cover us. We did the egg extraction, and just as the last presenter mentioned, it is an emotional roller coaster ride. So we took a little bit of time off after we got our embryos. We were so lucky. We got a bunch. So if we want, we can have more little Hazel Graces because she's so cute. But so we took a little bit of time off before we started our search for a surrogate. So then after about 3 or 4 months, we are both in marketing. So we thought, okay, we decided to go an indie journey instead of through an agency. We had just heard really bad horror stories about agencies, and it's not regulated in Canada, and it's just such a gray area, and we just got spooked. And it cost another $10,000 to go through an agency. And the whole process already cost us, by the time it was end and done, I think almost $30,000, give or take. So we did an independent journey. So we are marketers. So we thought, okay, if we were to attract a client or a customer, how would we do this? So we actually built a website. We filmed a video. The video went semi-viral, I guess. It got shared 30,000 times. And people were able to fill out the form on our website. And we had, how many people did we have? I think 15 or 20 people message us saying they'd love to help us. And then just from their emails and corresponding through emails, I talked to 4 on the phone. And then out of the 4 that I talked on the phone, I was really looking for that connection. And I met, I think, 2 or was it 3 in person. And then we chose our surrogate based on the fact that we got some really awesome advice from someone. Look for someone who isn't just going to be, for lack of a better term, a vessel for your child. Like, look for someone who you could be friends with, because 9+ months, it ended up being 2 years before we had Hazel after we met our surrogate, is a long time. So you have to really like that person. So I thought that was really good advice. So we went on like a date out for coffee and lunch. And if you could see yourself going on a second date and you didn't talk about a baby the whole time, then this person you could probably have a relationship with for the X amount of years or months that it would take. So that was some really great advice that we received on how to choose a surrogate. After we found a surrogate, it didn't end there. We thought, oh, perfect, we've got a surrogate. We'll be pregnant in like a month. It took 2 years. It took a full year before our surrogate was ready to be pregnant. So she had to go through her own, she had, polyps, and we paid to have those removed, and we had to get the lawyer contracts. That was almost $7,000. We had to do 2 or 3 rounds of drugs to thicken her uterus lining. So it was a whole process in itself. So that took a year. And then we became pregnant, thankfully, on the first try. So we were very, very lucky. And it was, that whole year was emotional. The year leading up, getting the embryos was emotional. The 9 months of being pregnant was emotional because we didn't have control. Again, I still struggled with, oh my gosh, am I even gonna connect with this little person? I didn't get to carry her. Will she know she's my mom? Like, I'm her mom. So again, I struggled with all those things too. And it was really, really emotional. And you have to have such a strong support system, which I do, thankfully. My husband is wonderful and he never wavered. He was great through the whole thing. Our surrogate, I watched the birth and I just can't believe that someone would go through that for someone else. Helena let me watch the whole thing. I saw Hazel being born and it is freaking wild. I can't believe that she did that for someone else. So Hazel is amazing, and it's been amazing, and I'm so glad we made this decision. And I did connect with her, and I love her to pieces, and it's been the best. But yeah, that's my story. I think that's it.
Wow, thank you so much. Your talk was very powerful. And I think just so important for people with CF to hear that real personal experience. So thank you so much.
Oh, you're welcome. My pleasure.
We'll now take questions. Thank you to everyone who already sent in their questions. If there are any additional questions, please use the WebEx chat box to submit your questions, and then I can read them aloud to Dr. Ladores and Hattie. I'll go through a couple of the questions. A lot of them have already been kind of addressed through both of your presentations, including, kind of recommendations and guidelines post-transplant. Dr. Ladores, you covered that quite well, along with medications and safety with pregnancy and breastfeeding. You covered that, which was really helpful. Along with pregnancy and family planning and when it's actually not recommended post-transplant, you covered that as well. I'm wondering if both of you can maybe talk a little bit about how to manage or cope with unplanned pregnancies. Sorry, this is probably not related to Hattie, but maybe Dr. Ladores, you could talk about just kind of what to do for unplanned pregnancies post-transplant.
Yes, thank you. That's a great question. And it's funny because some of these conversations are happening more in the US with the Trikafta medication. So not specific to the post-transplant population, but I'm sure you've probably heard that women on Trikafta here, the triple combo med, they're getting pregnant, it seems, left and right. And some are welcomed and happy news to receive for the women and the couples, but some are not. And so it's a mixed bag. And so for the women who are post-transplant and inadvertently becomes pregnant, I think the first thing that needs to be done is to let your transplant team know as soon as you find out. And so then they can figure out what the next best course of action would be in consultation with most likely a high-risk OBGYN and a maternal fetal medicine specialist or a perinatologist. So there's a lot of different people that needs to be consulted if the pregnancy occurs without plan. And there could be many recommendations depending on the health of the woman. If the woman is pretty stable, at least 2 years post-transplant, no rejection, no infection, everything else seems to be okay, then maybe the recommendation from all the team members would be to, okay, let's see if we can decrease the dosages of your anti-rejection meds and monitor you very closely. Or if the woman is not very healthy or not very stable, then the recommendation could be that an elective, abortion must be done in order to preserve the life of the mother, the woman. So these are really hard kinds of conversations, and gosh, I mean, these conversations are so individualized. So it's not one blanket Each woman will present differently. Each healthcare team will try to manage it differently, depending on their experiences, what resources and support they may have for their hospitals, and so on. So it's not necessarily an easy question to answer, but that's the best that we can do at this point, because there's no real, fully accepted guidelines on this topic.
Thank you. If anybody has any questions to ask, if they want to share them using the chat boxes, that would be a good time. I've gone through the the list of the questions that were submitted early, and I really, both of your presentations were so detailed and just really impactful. So I think we've covered all of the questions already, and I don't see any other questions. Do either of you, just before we wrap up and close, do either of you have any kind of final words of advice, or would like to share any thoughts, either of you?
Well, my advice would be find a fertility clinic that is nice and believes in you, that you can have a child and be happy like everyone else too. I know one of my friends went to a fertility clinic and he was so rude to her. So that would be my advice. Keep fighting, because we deserve happiness too, and babies bring a lot of happiness. So that's just my advice.
I guess my closing advice, well, first comment is I've really enjoyed listening to Hattie's talk and sharing her experiences, but she mentioned a couple of things about making sure that you have good family support, and that, if one center declines your request to, let's say, look at planning for a pregnancy, then maybe that's not the clinic for you. Then go on and explore other options. But, Hattie mentioned that she had to do a lot of learning on her own, and reached out to other people who may have experienced similar things, like the power of social media. Man, you guys are super smart as marketers to go through that journey as independent as you did. That's amazing. And so, you have to be kind of creative and think outside the box. Family.
Well, I would just like to thank you both so much for your presentations. Thank you for putting the time into these really great presentations. I found them very interesting and very impactful and informative. And as people with CF, it's such an isolating disease, and so trying to find this information out there can be tough sometimes. So thank you so much for sharing it today. And thank you all for tuning in. Our Fertility and Family Planning series will continue next month. Our upcoming webinar will be on the adoption process, and we invite you to keep an eye on our Facebook page for more information on the series. All questions can be directed to advocacy@cysticfibrosis.ca. And this webinar will be recorded and will be made available for future viewing as well. Again, thank you, Hattie, and thank you, Dr. Ladores, so much. And thank you all for tuning in.